Welcome to Teaching Service Hospital Rounds. Today we are covering acute mesenteric ischemia. This topic has one defining clinical sign and one defining constraint. The sign is pain out of proportion to the tenderness you find on examination. The constraint is time. The bowel infarcts within hours, not days. Put those together and the whole topic becomes clear. You have to suspect it before anything objective supports you, because by the time the examination and the laboratory studies turn abnormal, the window has closed. We will follow one patient from the door to the operating room. Let us begin. This is one of the few diagnoses where thinking of it is genuinely harder than treating it. Here is our patient. A 72-year-old woman arrives with 2 hours of abdominal pain. It came on suddenly. It is severe, and it sits around the umbilicus. She vomited once and has passed one loose stool since it started. And here is the observation that matters most. She is writhing on the trolley in obvious distress, and yet her abdomen is soft when you examine it. Hold on to that line. That mismatch between how she looks and how her abdomen feels is the whole diagnosis. Everything else today explains it. She has no fever, and she has never had abdominal surgery. Here is what to take away. First, define acute mesenteric ischemia. Name the 5 causes with their frequencies, and explain why the superior mesenteric artery is the vessel involved. Second, separate embolism from thrombosis clinically, and recognize pain out of proportion to the examination for what it is. Third, interpret the laboratory findings honestly. Choose the right imaging test, and state the mortality and what predicts survival. And fourth, deliver the initial treatment bundle, and match definitive therapy to the specific cause. Chronic mesenteric ischemia and ischemic colitis are separate videos in this series. Let us take the history. The pain began suddenly 2 hours ago, and it reached maximal severity within minutes. That opening matters. A pain that is worst at its onset is a vascular or a perforating process, not an inflammatory one that builds over hours. She vomited once and passed one loose stool. She has no fever and has never had anything like this before. And the pain is unrelieved by changing position or by vomiting. Sudden, maximal at onset, visceral in character. Treat that combination as vascular until you disprove it. There is no radiation to the back and no history of aortic disease. Now the rest of the history. She has atrial fibrillation. She was on apixaban, and she stopped it 6 days ago for a dental extraction. She has hypertension and hyperlipidemia. Her ejection fraction is 45%, and she has a 40-pack-year smoking history, quitting at 60. Now find the highest yield line in that history. It is atrial fibrillation off anticoagulation. A left atrium in fibrillation forms clot, and when the anticoagulant stops, that clot can leave. Everything else is background. 6 days is longer than most dental procedures actually require off anticoagulation. Now examine her. She is in severe distress, pale and restless, and unable to find a comfortable position. And her abdomen is soft and only barely tender. There is no guarding, no rebound, and bowel sounds are present. Her pulse is 104 and irregularly irregular. Notice what just happened. Most abdominal emergencies give you an abdomen that matches the complaint. Here, the abdomen actively contradicts it. That mismatch is not a confusing finding to be explained away. It is the finding. Her rectal examination finds no mass, and stool is present in the vault. Her laboratory studies. Her white count is 14,000, mildly raised. Her lactate is 1.8, which is normal. Her amylase and lactate dehydrogenase are mildly elevated. Her creatinine and electrolytes are normal, and her fecal occult blood test is positive. Now look carefully at that lactate. It is normal. And in a patient this unwell, that feels reassuring. It should not. A normal lactate at this stage is exactly what we expect, and treating it as reassurance is the classic trap in this disease. Her white count of 14,000 is real, but entirely nonspecific. Let us define the condition. Acute mesenteric ischemia is reduced or absent blood flow to the small intestine. It is usually arterial, involving the superior mesenteric artery or its branches, and that can be either an occlusion, a physical blockage, or transient hypoperfusion where the vessel is open but flow is inadequate. Less often it is venous occlusion, where the problem is drainage rather than supply. Those 3 mechanisms, arterial occlusion, arterial hypoperfusion, and venous occlusion, organize everything that follows. Note the word small intestine. The colon has its own ischemic syndrome. Follow the 4 mechanisms across the screen. In arterial embolism, a clot forms somewhere else, usually in the heart, travels down the aorta, and lodges in the superior mesenteric artery. In arterial thrombosis, there is no traveler. Atherosclerotic plaque at the vessel origin has been narrowing for years and finally closes. In nonocclusive hypoperfusion, the artery is entirely open, but the flow through it is inadequate. And in venous thrombosis, the outflow blocks, the segment congests, becomes edematous, and then infarcts. Each one has a different definitive treatment. Identify which mechanism you are facing, because it decides the operation. Here are the 5 causes with their frequencies. Arterial embolism accounts for about 40 to 50% in the setting of atrial fibrillation, valvular disease, or aortic plaque. Superior mesenteric artery thrombosis is about 20 to 30% from atherosclerosis at the vessel origin. Nonocclusive mesenteric ischemia is about 10% from low cardiac output, sepsis, or vasopressors. Mesenteric venous thrombosis is about 5%, and focal segmental ischemia is under 5%. Embolism and thrombosis together are 3/4 of all cases. Frequencies are worth memorizing. They set your pretest probability at the bedside. Take arterial embolism first. It is the single most common cause at 40 to 50%. An embolus forms elsewhere, travels through the aorta, and lodges in the superior mesenteric artery. Atrial fibrillation is the classic source, because a fibrillating atrium does not empty properly and forms thrombus in the appendage. Valvular disease is another source, including endocarditis, where vegetations embolize, and atheromatous plaque in the aorta itself can shed material downstream. Look at our patient again. Atrial fibrillation. Anticoagulant stopped 6 days ago. Ask about recent cardioversion and recent procedures requiring anticoagulation holds. Why does the superior mesenteric artery collect these emboli rather than another vessel? Because of its anatomy. The superior mesenteric artery leaves the aorta at a narrow, shallow, forward-pointing takeoff angle. Most aortic branches come off closer to a right angle, which means an embolus traveling down the aorta tends to shoot past them. The superior mesenteric artery points the same direction the blood is already moving, so an embolus follows that line straight into it. This is anatomy, not chance, and it is why one artery dominates this disease. The celiac and inferior mesenteric arteries are struck far less often for the same reason. Now, superior mesenteric artery thrombosis, about 20 to 30% of cases. Here, the mechanism is atherosclerosis at the origin of the vessel. Plaque has been narrowing that origin for years, and eventually it occludes completely. Other causes include vascular injury from abdominal trauma, infection, and mesenteric dissections or aneurysms. Now, here is the clinically useful part. These patients frequently have a history of postprandial abdominal pain and fear of eating. Chronic mesenteric ischemia came first, and the acute event is the endpoint of it. So the prodrome is diagnostic information. Ask for it deliberately. So how do you separate embolism from thrombosis at the bedside? Embolism is abrupt with no warning. The patient was genuinely well an hour ago. There is usually a cardiac source such as atrial fibrillation, and sometimes evidence of emboli elsewhere. Thrombosis has a long prodrome. These patients have diffuse atherosclerosis, and months of postprandial pain, food avoidance and weight loss preceded the acute event. So ask about the months before, not just the hours before. The prodrome, or its absence, is what tells them apart. Thrombosis patients also more often have claudication and coronary disease. Nonocclusive mesenteric ischemia is about 10% of cases, and it is conceptually different from the others. The artery is open. The flow through it is not adequate. What happens is that in shock or low output states the body constricts the mesenteric bed deliberately to divert blood to the brain and heart. The gut is sacrificed to defend central perfusion. And here is the diagnostic difficulty. Angiography can show patent vessels while the bowel is dying. So a normal computed tomography angiogram does not exclude this diagnosis. You have to think of it. It is also the form most likely to arise in a patient already in the intensive care unit. What drives nonocclusive ischemia? Reduced cardiac output. Underlying atherosclerosis, which lowers the reserve available. Sepsis, and drugs that reduce gut perfusion. Vasopressors, cocaine, and amphetamines. Sit with the vasopressor item for a moment. The medication we give to support a failing blood pressure constricts the mesenteric bed as part of how it works. So the intensive care patient on escalating pressors is being treated and being harmed by the same drug. That is why the treatment slide will say minimize pressors. Digoxin and ergot compounds are also described as contributors. Mesenteric venous thrombosis is about 5% of cases, and here the problem is outflow rather than inflow. The mesenteric vein clots, so the segment of bowel it drains cannot empty. Blood continues to arrive but cannot leave. So the segment congests, becomes progressively edematous, and eventually infarcts. Because that process takes longer than an arterial occlusion, the onset is more insidious and patients present later in their course. And one technical point that decides the diagnosis. It is the venous phase of the computed tomography, not the arterial phase, that shows it. Bowel wall edema on the scan can be the first thing anyone notices. What does mesenteric venous thrombosis travel with? Hypercoagulable states, portal hypertension, inflammatory bowel disease, malignancy, inflammation, specifically pancreatitis and peritonitis, pregnancy, trauma, and recent surgery. Notice the difference in patient profile from arterial disease. Arterial mesenteric ischemia is a disease of older patients with atherosclerosis and atrial fibrillation. Venous thrombosis appears in younger patients with a prothrombotic condition. So a younger patient with abdominal pain, and any of those deserves a venous phase study. In a first unprovoked event, a thrombophilia workup is reasonable afterwards. Focal segmental ischemia of the small bowel is the smallest group at under 5%. Here vascular occlusion affects only short segments of small bowel rather than the whole territory of an artery. The causes are vasculitis, atheromatous emboli, strangulated hernias, and radiation injury. Because only a short segment is involved, these patients are often less catastrophically ill than someone with a proximal superior mesenteric artery occlusion, and the treatment is typically surgical resection of that segment. Small territory, more survivable, still needs an operation. Always examine the hernial orifices in an acute abdomen. A strangulated hernia is findable. Now the cardinal clinical finding of this entire topic: sudden intense abdominal pain that is out of proportion to the tenderness you find on examination. When you meet that combination, treat it as arterial occlusion until you have proven otherwise. The patient looks far worse than the abdomen feels. And here is the mental correction to make. A benign abdomen in a patient with severe pain is not reassurance. It is the clue. In almost every other abdominal emergency, a soft abdomen makes you relax. In this one, it should make you move faster. Write that phrase in your differential, pain out of proportion, and act on it. Why do the pain and the examination disagree? Early ischemia is visceral pain. It arises from the bowel itself and travels on autonomic fibers, so it is poorly localized and severe but produces no tenderness. The peritoneum, which is what generates guarding and rebound, is not yet involved. Peritoneal signs appear only once the bowel wall has infarcted through its full thickness and inflamed the overlying peritoneum. And by that point, the therapeutic window has closed. So a soft abdomen buys you the diagnosis. A rigid one means you are already late. This is also why analgesia does not obscure the diagnosis. The sign is the absence of tenderness. The other causes present differently. Venous occlusion is often more insidious in onset, with intermittent pain that comes in peaks and valleys rather than one sudden maximal event. Nonocclusive ischemia presents with abdominal distension and pain, nausea and vomiting, and lower gastrointestinal bleeding caused by sloughing of the ischemic mucosa. And there is usually a context. Nonocclusive disease often follows an episode of hypoperfusion, a cardiac event, or a shock state. So ask what happened to the patient in the preceding day. And nonocclusive disease may present in a patient who cannot report pain at all. What does the abdomen actually show across the course? Early it is unremarkable, possibly with some distension, and nothing that matches the severity of the pain the patient is describing. Late it becomes peritoneal, with guarding, rebound, and rigidity. But understand what that late finding means. It means infarction has already occurred. So peritonitis in this disease is not a helpful confirmatory sign. It is a marker that you have missed the window. One more useful number. The fecal occult blood test is positive in about 75% of patients. So a positive fecal occult blood test supports the diagnosis, but its absence excludes nothing. How is the diagnosis actually made? The source says it plainly. Diagnosis relies on a high level of suspicion. Nothing else will make it. There is no screening test that reliably rules it in or out early. Rapid diagnosis is essential to avoid infarction. And infarction occurs within hours, not days. So the sequence that works is this. A patient with severe abdominal pain and a soft abdomen, particularly with atrial fibrillation or vascular disease, gets imaged immediately. The index of suspicion does the work that no laboratory test can. Put the vascular history and the soft abdomen together and image immediately. Here is what is at stake. Mortality runs from 20% to over 70% once the bowel has infarcted. That is an enormous range, and it reflects how much bowel is lost and how quickly the patient reached treatment. And the source states the single most important fact in this topic. Diagnosis prior to infarction is the strongest predictor of survival. Not which drug you choose, not which operation. Whether you got there first. So speed is the intervention. You are not racing toward a treatment. You are racing the infarction itself. Every step in the pathway should be measured against that single sentence. Now the laboratory trap. Laboratory studies are often normal early in this disease. Read that again and let it change your practice. Normal laboratory results do not exclude acute mesenteric ischemia. A normal lactate is common and expected before infarction has occurred, because lactate rises when tissue has already died and is producing it. So if you wait for the numbers to turn abnormal before you image, you have by definition waited until the bowel infarcted. The laboratory confirms the disaster. It does not warn you about it. Send them, but never let a normal result slow the scan. Here are the abnormalities when they do come. About 75% of patients have a raised white cell count. You may see elevated amylase, lactate dehydrogenase, phosphate, and D-dimer. And about 50% have a raised lactate, which the source explicitly labels a late finding. Understand the physiology behind that timing. Lactate accumulates once tissue is anaerobic and dying. So an elevated lactate in this disease is confirmation that infarction is underway. It is not an early warning. Use it to gauge severity, never to decide whether to image. D-dimer is sensitive but far too nonspecific to act on alone. What about the plain abdominal film? Early, before infarction, it is normal. As the disease progresses, you may see thumbprinting, which is thickening of the bowel wall from edema indenting the gas column. You may see ileus, and in later stage pneumatosis, gas within the wall of the bowel itself, which indicates necrosis. Now notice the problem this creates. A normal plain film is exactly what you expect during the window, when you can still save the bowel. So a normal film must never end the workup. Its main value today is excluding perforation and obstruction, not confirming ischemia. Computed tomography angiography is the non-invasive test of choice, and you want the arterial phase. It is fast. It is available in essentially every emergency department, and it maps the vascular anatomy so the surgeon or interventionalist knows what they are dealing with. One critical addition: when mesenteric venous thrombosis is suspected, ask specifically for avernous phase as well. The arterial phase can miss it entirely. And do not delay the scan for a creatinine that is only slightly abnormal. Contrast nephropathy is recoverable. Infarcted bowel is not. Tell the radiologist what you suspect. The protocol depends on it. Conventional angiography is the gold standard, and it has an advantage the computed tomography does not. It is potentially therapeutic in the same sitting. It is indicated when vascular occlusion is suspected. Through the same catheter, the interventionalist can perform an embolectomy by aspiration, deliver thrombolysis, or infuse a vasodilator directly into the mesenteric circulation for nonocclusive disease. So in the right patient, angiography is not simply a better picture. It is diagnosis and treatment combined into a single procedure. It also carries procedural risk, so it is not the first test in every patient. Now the initial treatment bundle: intravenous fluids and nil by mouth. Optimize hemodynamics and specifically minimize vasopressors. Broad-spectrum antibiotics, because the ischemic bowel wall translocates bacteria. Anticoagulation with heparin, with or without tissue plasminogen activator for occlusive disease. And intravenous papaverine, a vasodilator, specifically for nonocclusive mesenteric ischemia. Sit with the pressor instruction. The drugs holding the blood pressure up are constricting the gut, so the resuscitation strategy has to shift toward volume. Volume resuscitation is preferred over pressors, wherever the blood pressure allows it. And now the decision that overrides everything else. If there is evidence of peritonitis, the patient goes to the operating room. There they receive surgical and endovascular therapy, plus resection of the infarcted bowel. Understand the logic. Peritoneal signs mean infarcted bowel is already present, and infarcted bowel does not recover with anticoagulation or a stent. It has to come out. So no further imaging should delay that transfer. Once the abdomen is peritonitic, the diagnostic phase of this disease is over. A second-look laparotomy is often planned after resection to reassess bowel viability. Definitive therapy follows the specific cause, which is why identifying it matters. Superior mesenteric artery thrombosis is treated with percutaneous stenting or surgical revascularization. Superior mesenteric artery embolism is treated with embolectomy, either catheter-based aspiration or surgical. Nonocclusive ischemia is treated by correcting the underlying cause, especially the cardiac one. Mesenteric venous thrombosis is treated with heparin, followed by 3 to 6 months of anticoagulation. And focal segmental ischemia is typically treated surgically by resection. And every one of them still needs the initial bundle running alongside. The pitfalls that cost patience. First, taking reassurance from a soft abdomen in a patient who is screaming with pain. Second, waiting for the lactate to rise before ordering imaging. Third, ordering a plain film and stopping there when it returns normal. Fourth, missing the venous phase in a young patient with a hypercoagulable state. Fifth, escalating vasopressors in nonocclusive ischemia and worsening the very perfusion problem you are treating. And sixth, imaging a patient who already has peritonitis instead of calling the surgeon. Every one of those 6 is a decision made in the first hour. Back to our patient. She had computed tomography angiography, arterial phase. Within 40 minutes of arriving, it showed an abrupt filling defect in the proximal superior mesenteric artery, an embolus. The distal branches of that artery did not opacify, confirming occlusion. Critically, the bowel wall was not thickened and there was no pneumatosis. Soche has not yet infarcted. And on the cardiac views there was thrombus in the left atrial appendage. The source. She was imaged before infarction, which is the single strongest predictor of her survival. Her lactate remained normal throughout, exactly as expected before infarction. So the assessment and plan. Acute mesenteric ischemia caused by superior mesenteric artery embolism from a cardioembolic source. Heparin is started immediately. Fluids are running, vasopressors are avoided, and broad-spectrum antibiotics are given. She goes for embolectomy without further delay, and afterward she needs lifelong anticoagulation for her atrial fibrillation. And one more thing belongs in the discharge plan: the anticoagulation interruption that caused this. 6 days off apixaban for a dental extraction was longer than that procedure required. Bridging strategy for future procedures gets documented in the discharge summary. Let us bring it together. Acute mesenteric ischemia is reduced flow to the small intestine, usually the superior mesenteric artery. 5 causes: embolism 40 to 50%, thrombosis 20 to 30%, nonocclusive 10%, venous 5%, and focal segmental under 5%. The superior mesenteric artery is hit because of its narrow, shallow takeoff angle. Sudden pain out of proportion to the examination is arterial occlusion until disproven. Laboratory studies are often normal and lactate rises late. Computed tomography angiography is the test of choice. And peritonitis means the operating room. Diagnosis before infarction is the strongest predictor of survival. These are the sources behind today's material: the definitions, causes, clinical picture, diagnosis and treatment. Follow the New England Journal of Medicine review of acute mesenteric ischemia, and the management detail follows the World Journal of Emergency Surgery guideline. Thanks for working through this one. Remember the 2 things that carry the whole topic: pain out of proportion to the examination and a clock measured in hours. If you hold both of those, you will make this diagnosis in time. See you on the next video. 2 sources, both current and both worth reading in full.